review of changes associated with the stages of Alzheimer's disease. Hillebrand is a physician assistant focusing on the whole person experience, treating the body, mind, and soul of people at Banner Alzheimer's Institute in Phoenix, Arizona. She has an interest in education and counseling related to dementia. Today, Helle provides tools for living with dementia, caregiving support, and whole body person-directed care. And before we start the presentation, I just want to do a friendly reminder to everyone on the line that on the right-hand side of your webinar, you will see a dashboard, and that is where you could type in your questions and we will answer. And just also, I want to let everyone know this is in listen-only mode. So questions will be saved till the end of the presentation. Again, we are in listen-only mode, and on the right-hand side, you could type in questions. In addition, that's where you'll find handouts from today's presentation. And so, Hillebrand, please, can you kindly begin today's presentation?
Thank you. Good morning to everybody, and afternoon, I guess, to those of you on the East Coast. I'm going to talk today about the changes that we see with Alzheimer's disease, maybe some of which you've already witnessed, some of which you may still be on the verge of witnessing. So one of the things that I always get asked, regardless of the presentation, and I want to make sure we're all on the same page, is what's the difference between dementia and Alzheimer's disease? When we're talking about dementia, we're actually talking about the cluster of changes, of symptoms that we're going to be exploring today. So dementia means, it's kind of an umbrella term, and that's why I use this image. It's identifying the changes in memory, in thinking, in mood and behavior and function. What it doesn't tell us is why are those changes occurring. And when we look at those reasons for why there is dementia, the biggest cause by far is Alzheimer's disease. There are those who think up to 2/3 of all causes of dementia is because of Alzheimer's disease, but then there are a host of other kinds of dementias as well: vascular dementia, dementia with Lewy bodies, frontotemporal dementia, the dementia associated with Parkinson's disease, for instance. And people can also have mixed dementias or combinations of different dementias. So again, dementia itself is not a diagnosis. It just identifies the symptoms or the problems or the changes that are being observed, and it's important to understand why, or to ask the doctor, is this Alzheimer's disease? So beginning very early on, we associate Alzheimer's disease with changes in memory and thinking. And by far the first symptom we want to hear you report, or a person with memory change report, is that they notice they were gradually becoming forgetful, experiencing short-term or recent memory loss. And an important part of this is that as you're going through it, you aren't always aware, because it's random events that happen, and then you as family members, you as a person with dementia, notice that it's happening more often. For instance, with my father, we noticed that he was not remembering birthdays as well. He was sending cards at the wrong time, apologizing for either being early or late, but never quite right, but then not remembering the actual birthday, and having trouble remembering what he had done the week before. So it's short-term memory loss and forgetfulness. The challenge becomes the family who are out of town and not living with a person with memory changes, unaware of these subtleties in short-term memory, because when they're talking, they hear the long-term memory come out. You know, what happened 20, 30, 40, 50 years ago. And so it can create a challenge in the early stages because not everybody's on the same page. Mom doesn't have any problem with her memory. What are you talking about? Or a person with dementia will also say that. I remember everything just fine, but if you ask them about the trip they took last week, for instance, they can't remember the details of it. Obviously, if I'm not remembering something particularly well, I'm liable to be repetitive in terms of what my questions are or what my stories are. So repetitiveness becomes part of those early memory and thinking changes. Keeping track of time, of dates, of appointments also is an early warning sign and becomes more of a challenge as the disease progresses. So initially it's forgetting those appointments, showing up at the doctor's on the wrong day or on the right day but the wrong date, not remembering events that were planned with friends. They show up at the door to pick someone up and they're not remembering that was supposed to happen. Along with that, we see confusion with place and time start to settle in fairly early and obviously become more pronounced as time goes on. And this becomes a concern, as we'll talk later, with driving. So I'm hearing from families that a loved one is getting lost or disoriented with driving, for instance. Keeping track of that time. How much time do I need to get ready? How much time do I need to get somewhere? When is my appointment? What do I need to accomplish in the day? All of those sort of time management skills become affected. Early on, we also see withdrawing from activities and interests, and this doesn't mean that they can't still do them necessarily or that they wouldn't be interested in doing them. It's just it's more challenging for them to do it. They're more self-conscious of the subtle memory changes, perhaps the language changes, having that trouble coming up with the right word at the right time. Patients often report to me, it feels like everybody's talking too fast because they're slower in processing information. And so the net result is that we observe a person with memory changes slowly becoming more an observer than a participant. One of the early changes, and that also becomes more pronounced as time goes on, is misplacing or losing things. Now, we're all guilty of this, especially today when we have to worry about our cell phones, our wallets, our purses, our glasses, our sunglasses. So we may all have times in our keys that we wonder where we set them down. The important thing is that when there are no memory concerns, we're able to retrace our steps, to think it through, to problem solve to where it's most likely those were left. The person who is experiencing memory loss for whatever reason, whatever kind of dementia, has difficulty with the problem solving. They can't retrace their steps. They're misplacing or losing things repeatedly, several times a day, and they're unable to find them. Now that becomes a challenge as the disease progresses, because sometimes as the thinking gets more confused, they then begin to accuse you or other people of stealing their items. Word finding difficulty I alluded to, and this is a subtlety that you notice. They have trouble coming up with a word you may be filling in for them, or you notice that they make a substitution. They use another word that's close, but something in your head says it isn't quite what they intended. They may also compensate by talking around a word, so using a descriptor or even gesturing. So for instance, if I ask someone what the knob on the side of the watch is called, they may not recall stem as a word, but they know that, you know, it's that thing you set the time with, and they even can be gesturing with their hands to show you that they know what it is. So when we look at the brain in early stages, if you look at the very center of that brain, the area that is blue represents areas that are beginning to have problems, and you'll see in further pictures in the course of the presentation that more and more of the brain is getting involved, and that the color is even deepening. So it means that the disease is not only progressing through the brain and presenting other challenges, it also means that each area that has been affected is more deeply affected. But that center area that looks almost like a thumb lying on its side is the hippocampus, and that is why we see the symptoms of forgetfulness. The hippocampus is responsible for our short-term memory, or for learning new things, new ways, new information, and those are all areas that start to have difficulty. If we look at the back part of the brain on the right side of your screen, that is the area of visual spatial skills. That part of the brain coordinates with the eyes to give us information on where we are in the environment in relation to everything else. It allows us to look at objects and to recognize them for what they are on the basis of the dimensions, the shape, the textures, the colors. All of that kind of information comes from the back part of the brain. It gives us information on distance, on depth, on direction. It allows us to see things in contrast. So if I have a pen on a desk, I can see the pen as separate, for instance. When that area is affected, it's going to cause some of the visual spatial changes that we're talking about. And then the left side of your screen, the frontotemporal area, is our executive planning kind of part of the brain that helps us manage our day, helps us make decisions, use reasoning and judgment to come up with well-informed decisions. It also helps us conduct ourselves in a good adult way, kind of the good citizen, and helps us control our mood or behavior. So when that area is affected, we're going to see some of the changes we're going to talk about now. So it isn't just memory that changes in Alzheimer's disease. Very early on and progressing through the whole disease, we see changes in function and the ability to do tasks, activities, engage in hobbies or other activities of interest. And what you see early on is that it takes longer to complete tasks, or they have less confidence to do things that were very routine for them. They begin to forget essential tasks. So it might take longer to cook initially, and I may not be as sure, so I may be using simpler recipes. I may then forget ingredients in the recipe, and then I forget how to cook and I stop cooking. So it's a gradual process of loss of ability to do things that were done automatically, efficiently, and well. We also notice that, remember I said the hippocampus is the area for short-term memory and new learning. So if for one reason or another you have to replace the microwave, or you give them a new cell phone, they have difficulty learning how to use that. Part of the functional change too is when we think early on of those household-related tasks, cooking, cleaning, managing medications, driving, paying the bills. It's also using technology. Can I use the microwave appropriately? Am I using all the settings on the washer and the dryer? Am I using the thermostat controls appropriately? Can I use the phone to retrieve messages, to make phone calls, for instance? So We see difficulty in that functionally, but if we have to replace any of that technology, they definitely have difficulty with that. And so what you find as family members or care providers is that you are gradually having to sort of prompt, to remind or to cue what the next step is, what needs to be done. You're stepping in more and doing things side by side. So maybe a husband has taken over most of the cooking, but she can still make the salad, for instance. And then it becomes a realization that you have to take over all of those executive tasks, or what you'll also hear referred to as instrumental activities of daily living. And the other big change that you see is that change in judgment or reasoning and problem solving. They become more concrete, more black and white in their thinking, simpler. When you try and reason with them, they get anxious or they get agitated or angry because they can't follow a line of reasoning. And this has implications for safety, and this has implications for capacity, who makes the decisions for them, as we'll talk. One of the challenges that we see is in visual, spatial, or perceptive abilities, and this is often misread as a problem with vision. I often hear care providers say, oh yeah, we've got an appointment with the ophthalmologist next week because he's not reading anymore. Well, it's not because he can't see, it's because his mind is not helping him perceive the letters, for instance, as parts of words or phrases or sentences or paragraphs. The other side of that is I have to be able to retain what I read in order to understand and stay with it. And so we see reading fall off as a functional skill, as an interest. So it's trouble judging distances and directions. Early on, it's that less confidence with driving, and the change you see is that they begin to whittle their driving area down to sort of what I call the miracle mile. Everything I need is within a mile of me. I get my hair cut, I go to the post office, I go to the store. Because anything beyond that is too challenging. Trouble reading and writing. Reading becomes simpler. You notice that they're letting go of big novels or nonfiction books. They're gravitating towards lighter stuff, towards fluff, and then towards magazines. They're often interpreted as reading the paper for a very long time, but if you talk to them about what they read, they're not able to retain it. The act of reading the paper is a well-preserved behavior, and it's more that they are scanning. Let's remember, too, that reading and writing are part of language skills. So language is the ability to read, write, speak, and understand, and all of those become progressively more difficult for people with memory changes. Obviously, if I'm having trouble judging distances or directions, I'm going to gradually have more trouble with driving, knowing how close I am, how far I am from a car, whether it's safe to make a left-hand turn, how to pull into a parking space without getting dinged, for instance, or just how to get home from where I am. The difficulty judging the color or the contrast I alluded to earlier. As time goes on, caregivers will say, oh, I tell him to go get his comb that's on the counter, and he's looking right at it, but he can't see it. He can't see it separate from the background. And the back part of the brain, remember, gives us information, perceptions. So when it's not working, it means that I am misperceiving. So I can look at images and think that they are something else. And this often makes it sound like somebody is hallucinating, but they're actually looking at something and calling it by another name. Shadowy images can be misinterpreted, for instance. And with the difficulty in judging distances and directions and recognizing sort of familiar places in the environment, it means that with time, people with Alzheimer's disease don't recognize or can't orient to familiar places as well. I see a lot of this because we have so many snowbirds in Arizona, and they go back and forth, and caregivers say, when we get home back east or when we come here, he can't orient to the house. He can't find his way around the house. It agitates him. Or the opposite when they come here. And at some point it becomes too stressful and we have to let go of that travel back and forth. We can see changes in personality beginning early on in mood and behavior. And as time goes on, it's easy to say that they're doing this on purpose, that they're being willful, that they are manipulating you. They may say hurtful things, and because you've had so many years with them and because you're trying so hard to help them, it hurts to hear these kind of messages. The important thing is to remember this is a progression. This is a disease that is progressing through the brain and causing these changes. What we can see is increased irritability and frustration early on. You can appreciate if it takes you longer to do something, if you don't understand what the next steps are, if everything you try to do doesn't work well, and then somebody is there telling you how to do that, how that can make you feel more irritable or frustrated. That can escalate to full-blown anger, for instance. We can see increased anxiety. Again, how do I make sense of the day? What's going on? What do I do next? What does this mean? Particularly if somebody is either living alone or being left alone in the early stages. But anxiety becomes a big part of the picture as the disease progresses because they become dependent on you as family care providers to make sense of their day. So if you're out of the picture, if you're in a different room, you see separation anxiety. They come looking for you, much like a child might, right? Young mothers just want 2 minutes in the bathroom alone, for instance, but they want to know where you are. They may not want to go to sleep at night because you're not in the bed with them. They can become depressed, and actually depression after the age of 65, new onset depression, is often one of the earliest warning signs for potential memory changes brewing. So it's a warning sign for Alzheimer's disease, and it's a risk factor associated with Alzheimer's disease. There can be the depression with the diagnosis. There's a depression that comes with the sense of things that have been lost, independence, the ability to do things, a sense of helplessness or hopelessness, nothing to look forward to. And that's the challenge, is how do we affect quality of life by giving them something hopeful, something to look forward to? How do we engage them on a day-to-day basis so that the focus is on what's still here rather than what's not? And that's equally true for family members who are providing care, because sometimes the grief is so real that it is more about what's lost rather than what's here now in the present. With depression, with more difficulty engaging or being able to understand or feel comfortable with people, we can see that withdrawal and isolation. Apathy can set in, and apathy is really difficult because that's the person who has no interest, doesn't want to do anything regardless of how you approach them, would just as soon sit. Often it's more that that front part of their brain is having trouble planning the day. And so what you as care providers would report to me as they're transitioning into moderate stages, it's like they're lazy. They don't do anything. And again, here's that it's willful or manipulative. You know, if it's something they like to do, then they're fine. Well, what does that say? It's something I like, I can engage in, and you're doing it with me. I look forward to that. But if you expect, as I've lost the ability to remember how to use the vacuum cleaner, how to cook, and you're still expecting me to participate in those activities, I can't do that. So it's that supervision from afar moves into closer, that we do it together in order to make things happen. As lines of thinking become more and more confused, we can see suspiciousness set in, and that can in fact become frank paranoia that interferes with care, as they may think you're trying to poison them or steal their money, for instance. And then another big change that we see is more impulsivity. So early on, they can be spending money that they don't have. They're in the grocery store, and we know that there are gradual changes in food preferences for many that gravitate towards sweets or salt or spicy, so comfort foods. And as I'm having trouble cooking, but I'm still trying to shop and still trying to hold on to old ways, I'm going to go for the easy things. And so this is where early on we see lots of cookies and snack foods. That's what they're living on. They can not only spend money, but with time, between impulsivity and disinhibition, be overly friendly with people, bolt from cars, take things in the store when you're with them, and start eating them without any regard for having to pay for them, for instance. So in the early stages, the concerns because of these gradual changes that we're seeing become for medication management. If I can't track time and I have short-term memory loss, it means I may not remember whether I took a pill or whether it's time to take a pill. So medication management needs to get assumed fairly early. Driving, it's the concern for either getting lost or doing harm to self or others, causing an accident, for instance. Weight loss is a concern, especially if somebody is living alone or being left alone, because with time, remember, the short-term memory is becoming more and more of a challenge. Now they're not remembering to get food for themselves. And the act of getting food has many, many steps. It takes a lot of planning. I have to go to the refrigerator, the cupboard, the pantry, the drawers, in order to be able to pull something together. So the net result is I'm not getting those meals. Even though you've left food for me, I'm not remembering to eat it. Even though you've put Meals on Wheels in place, I'm not remembering to use it. And curiously, at this same time, I always ask, is the dog getting fatter? And that's often the case. The real concern becomes as they're losing their ability to perceive the world as they did before. It means that they can't perceive situations as safe or unsafe, good or bad, right or wrong, for instance. And so they become more vulnerable, more at risk for exploitation, for being in an emergency situation and not being able to interpret as such, and more importantly, to not be able to respond to it. Technology is phone use, for instance, and it's unrealistic to think that if somebody is no longer making phone calls, that they're going to recognize the need to call 911 in an emergency situation. Early on, we need to make sure that life planning is in place. Do we have financial planning done, financial powers of attorney completed? Has there been legal counsel in terms of estate planning, wills, medical considerations like power of attorney, living wills? All of those need to get done very early. And the important thing is if you've done them as a couple, you have to revise your own, because he or she is not going to be able to make decisions on your behalf. And a very real challenge becomes, who's caring for whom? Who are we identifying as the participants in care within the family? And another challenge is Alzheimer's is very much a part of aging. The older we get, the greater our risks. And if we have a couple, it's possible that both of them can have different stages of Alzheimer's, and that presents more significant care planning issues. So when we look at the moderate stage, as I said, the darker the blue that you see on the images, it means that there's more significant impairment. So you can see the short-term memory. This is where you say in one ear and out the other. And it's progressing through the brain. So in the moderate stage, what we see is the loss of those household-related tasks, those executive tasks or instrumental activities of daily living, and now they begin to have trouble taking care of themselves, combing their hair, brushing their teeth, changing clothes daily, wearing clothes appropriate to the season or the event, bathing in mid-moderate stage, eating, being able to cut up foods, for instance, use utensils appropriately. The memory loss becomes severe in the short-term memory, in one ear, out the other. Whatever I just said, it's forgotten minutes later. But now we also start to see gradual changes in long-term memory as well. Remembering who the extended family is, how they're related, recalling names of extended family even from the past, remembering who's alive and who's not alive. And then as we progress farther through that stage and into the end stage, even losing what we call biographical data. Where was I born? How many brothers and sisters did I have? If and when I got married, if and when I had kids, where did I work, where did I go to school? Language becomes more and more of a challenge, so more difficulty expressing themselves by the end stage. Sometimes we hear just garbled speech or what we call word salad. They talk, but you can't find any element that blends everything in together. Or they can become mute, not be talking at all. They have more difficulty understanding. You find that you have to simplify directions, choices, so that they can understand. And then the reading and the writing are lost as well. More difficulty with recognizing time and place, so that at some point they even get lost within their own house. They get up to go to the bathroom and end up in the wrong part of the house. They may ask, whose house is this? Or as thinking becomes more and more in the past, even ask to be going home, and you find you want to reason with them that this is their home, but their reasoning is gone. They can't problem solve anymore. They have no judgment about situations. The personality and behavioral changes that we talked about in the early stage can become more pronounced or develop now if we didn't see them early. The vulnerability is such that in the moderate stage, they need 24/7 supervision. They cannot be left alone because they cannot respond to an emergent situation. Even more importantly, they can't recognize an emergent situation. We can see also across sort of the mid top part of the brain is the motor area of the brain. We can see gradual changes in posture, becoming more stooped, changes in walking speed, and in balance, becoming progressively unsteadier to a point of cruising along furniture or holding on to people. And the net effect here is that if you weren't having trouble before, now you're noticing that the stress is becoming significant, because in the moderate stage you assume all household responsibilities, and now you're also directly providing care for them. So the issues in the mid-stage that we worry about, behaviors by far are one of the biggest concern. I'm sure any of you could list 4 or 5 behaviors, from repetition to anger to agitation to paranoia to aggression, right on up the scale. Risk for wandering. They can leave the house, they can wander away quite quickly and may not be found for some period of time. We gradually see change in both sleep and eating patterns, and it becomes more challenging for you as care providers, because you have to constantly be modifying your own interactions, changing your language with them, changing your expectations, and what worked today might not work tomorrow but might work the next day. So it's a constant adjustment on your part, and it becomes stressful and hard to keep a focus on. The reality is that this person with memory loss cannot change. This is the way it is. So we have to move into their world. So one way that you reduce stress at this point is you share the care. What are the community or the family resources that are available to you? This is often a time where one aspect of care becomes, do I place my person or not? And there's no right or wrong to that. It's whether your heart and mind are in sync. Are there safety concerns? Are they falling and not able to get up? Is your own health been affected, either emotionally or physically, such that you're not able to provide care anymore? And then a significant risk factor is delirium. So we call this the voice of dementia, and that is a response to illness, to medical, health, or physical stressors. And when there is something brewing in the body, they often will act it out. They'll either become agitated or more confused, not sleep, be increasingly restless, or go the other way and be non-responsive. And it comes on very quickly, over hours to days, as opposed to the gradual change that we see. By late stage, we're looking at most of the area being affected, and you can see across the center top of the brain there, that's the motor area, and this is where we can see other neurologic changes other than the change in walking posture and speed. We can also see things like difficulty swallowing begin to occur at this point. In the late stage, we're looking at severe memory loss. As I said, short term is essentially gone, and now even the long term and connection with the past is lost. Verbal ability may become very limited, very confused. They're oriented only to self. They may recognize you as a trusted person, but they won't have been calling you by name or relationship for some time. They have no independent self-care function. In other words, you have to do everything for their personal care. And a hallmark of the late stage is the development of incontinence of both bowel and bladder. And where behaviors often are a trigger for placement, it just wears a care partner down. In moderate stage, in late stage, incontinence is often a trigger because it requires much more physical strength on your part, because now you have to change them, maybe you have to clean them up, you have to do more laundry. People in later severe stage dementia can also have very limited mobility. Some lose the ability to walk, some become bedbound, some can still walk but with a lot of assistance and for very short distances. I'm also going to just stress that this is a general overflow to how changes happen. It's predictable that all of these skills will be lost and that there will be full dependency, but the course for each person is a little bit different. Everybody has different strengths and weaknesses. So I see some people who have more preservation of language late, others who have more preservation of mobility, for instance, are able to keep walking, but are much more pronounced in the other areas. And the issues in advanced Alzheimer's disease, and then we'll open it up to questions, becomes the risk for falls. They're unsteadier, they don't perceive depth or distance, they don't scan their environment, so it means they can trip over things very easily, they can run into things, they can misjudge stepping over a threshold. They gradually have become weaker, and so they have no strength when they get up to stand, and when they're walking they can kind of crumble quickly. So the risk for falls becomes huge, and that can potentially end up in hospitalization with fractures or head injuries. We can see recurrent infections, urinary tract infections in particular, as the hygiene has changed, as incontinence sets in. It's a breeding ground for infection, and even skin breakdown with incontinence. As they're less mobile and sitting or lying in one position, we worry about skin breakdown, particularly if in the very late stages we start to see a weight loss that is a failure to thrive. In other words, they're eating well, you're getting good intake in, but they're not holding on, they're just shedding pounds. That's failure to thrive, and that's where we look at planning for death and dying, that this is an appropriate time for hospice referral. So when we have somebody fully dependent for all care, housebound, falling or having risk for falls, and having a weight loss of at least 10% of their body weight in a very short period of time, this is where we shift the focus to comfort and how do we want their last weeks or months or year to go. In this whole process, you will have noticed increasing sleep with time, both through the day and intermittently through the I'm sorry, I said that wrong. Longer at night and more intermittently, and then longer even during the day. We can also see neurologic changes, as I said, with difficulty swallowing, but also they can develop these kind of random jerks in their body called myoclonic jerks, or even seizures for some. So in summary, Alzheimer's disease is progressive. When it starts, it's insidious. You aren't aware of it at the moment. It's when you look back, you can begin to see the picture, but that first complaint, that first observation was the one of forgetfulness. It affects memory and thinking, which leads to increasing confusion and memory loss, both short and long term. It affects the functional abilities initially at work or at home, and then in personal care, and this leads to dependency for all care. It can affect mood, personality, and conduct, which means we can see behavioral changes, and it affects problem solving, reasoning, and judgment, which leads to vulnerability, safety concerns, and also leads to the whole issue of you needing to make medical and financial decisions for them. With that, we'll open it up to questions.
All right, thank you for such a great presentation. And so now I will be reading questions, and we have our first question from Carol. And her question is, how do you compete against withdrawal or isolation? My mom is so polite that it hides her dementia, but her politeness keeps her friends at bay. I don't want her to lose her connections.
Great question, because you've spoken to the heart of the matter. We don't want them to lose connection. So I think there are a couple of things involved early on here, and you pointed to them. One, they're good at covering up when they're having problems. They can laugh, make jokes, talk around, explain things away. A real consideration is they don't want to be a burden to people, and this creates a conflict within the family. You want to give back, they don't want you to be burdened. So I think it's gradually introducing things. Who are the people you can trust to understand what's going on? So it means that you have to carefully share the diagnosis, note the needs, have people not ask, do you want to do something, but rather maybe stop by and make the visit short. Just, hey, I just heard about this new restaurant with takeout, and I just knew you would enjoy this, and just sit and have lunch. What's important is creating a regular, predictable routine so that it helps their brain and spirit orient to things to look forward to, not make them feel like they're being babysat, but that this is something they can enjoy. Sometimes it's family and friends. Sometimes it's hiring a friendly visitor or companion from a home care agency. It's recognizing what's the best time of day to make this happen for your loved one initially. It's looking at, are they better one-on-one, or are they so sociable that daycare may be a better setting for them, for instance.
Thank you. Thank you for that. So does anyone else, if you have questions, I just want to do a friendly reminder. On the right-hand side, you could type in your questions, and we will be happy to read them. So
I would just add to a general discussion. So early on, we know that driving is going to have to be surrendered, and this is one of the challenges is, what happens with driving. I will tell you that the hardest thing of all is I drive today, tomorrow I don't drive. It's looking at setting the stage for it. So gradually assuming more driving responsibilities. Doggone, your car's always in the way of their car, so I'll drive today. It's looking at wants and needs. When might they want to get out of the house? Why might they want to get out of the house? And anticipating those. So with my dad, for instance, a love of his was to go to the grocery store. We reduced his frequency of driving by anticipating that need and picking up his favorite cookies, for instance. Hey, Dad, I saw your favorite cookies were on sale, so I thought I would stop by. What have I created now? I've reduced his need, I've brought in something pleasurable, and I now have it connected socially. And that's often the way you begin to create that interaction with Mom, for instance, in Carol's case, is that people are just stopping by and expanding their role with time. And as they're visiting, think about what your person's past loves have been. And I want to go back years. What was the music they listened to? What hobbies or interests did they have? Because those are all things I can bring in and connect with.
Okay. So we also have other questions. May I ask those questions now? Is that okay?
Sure.
We have a lot of other questions ahead of us. Okay, so and for all of you guys, if we don't get to your questions, I just want to let you guys know you could call our helpline at 866-232-8484, 866-232-8484, Monday through Friday, 9 a.m. to 9 p.m. Eastern Time, and on Saturdays from 9 a.m. to 1 p.m. Eastern Time. Okay, so what do you do when mom lives alone and refuses to move in with any of her kids? And this question is for Amy. I don't know if you briefly want to review this with her on the line. If not, Amy, you could certainly call our helpline, whatever you feel comfortable with, Hella.
Yeah, so, you know, again, we know that living alone is not going to be a reasonable situation. So it's, again, what do we put in place? Can we buy some time and get mom a little bit more used to the idea of people around? Sometimes you have to be lovingly firm. You know, Mom, we decided that since you're retired now, you deserve to have some house cleaning, and now you get a home care agency in, and they're in there under the guise of house cleaning or light meal preparation, but they're also developing relationships. So sometimes you can put changes in the home for a while until mom is more receptive to moving. Sometimes she's never going to be receptive, and it just has to happen. You always take advantage of hospitalization or illness, for instance, as a reason. Sometimes you create a reason. Oh my gosh, your plumbing is broken or your electricity isn't working. Well, come on over here and we'll get somebody in. So you create a situation that creates the move. Those are strategies that have worked for lots of people. Sometimes it's who in the family delivers the message. So if everybody's on board that this needs to happen, you know, Mom, we would love for you to stay at home, but the reality is that you can't. We don't want to give long, extended explanations because she may not be aware of the diagnosis. That would be a simple answer, and you know, she can contact you for further.
Okay, thank you so much. We have another question from Amber. Could you please tell us the difference between dementia versus Alzheimer's again?
Dementia is simply the cluster of symptoms associated with memory loss. So it's changes in memory and thinking, mood and behavior, and function. So it just talks about the symptoms. You then have to identify the cause. It's kind of like cancer. We always reference cancer. You would not leave a doctor's office accepting that you just have cancer as a diagnosis. Cancer just means that there are rapidly growing abnormal cells in the body. You want to know what kind of cancer, and that's the question. What kind of dementia do I have? And in most cases, it's Alzheimer's disease.
Okay, thank you. And I have a question from Shamir. Can you tell us more about the myoclonic jerks? I'm not sure if I'm saying that correct. I see it as M-Y-O. Okay.
Yeah, myoclonic jerks. So in late stage, what you may see, it's kind of like think of it as just sort of a misfiring, right? Normally, your nerves and your muscles kind of are at rest. When you're sitting. If you, for instance, fall asleep while you're sitting, right, your body may jerk at some point when your head's down too far or just as you're falling asleep. That's kind of the same as what you might see as a myoclonic jerk. So as they're sitting there, all of a sudden their arm might just jerk up as if they were scared for a sec or as if they had just fallen asleep. There's nothing that you do with it. It's an observation.
Okay, thank you so much. Another question from Deb. Are depression and pain undertreated because they are not expressed the usual way?
Absolutely. Absolutely. And the other factor that becomes, a family who don't want to use medications for themselves. So depression, we sometimes have to recognize the symptoms, vegetative beyond what we would expect for that given point in time in their Alzheimer's progression. Excessive sleep, not eating or not sleeping, and periods of cheerfulness, right? So they may not be able to tell us, but they're showing us. The same with pain. We can see resistance to bathing as part of a normal progression in Alzheimer's disease, but is there resistance consistently with moving a limb, for instance? Is there a history of fall and we have to think that maybe they broke or hurt something? Are we seeing wincing? What is the body language suggesting? Do we know that they have a condition that can cause pain? We know they have degenerative joint disease, but we can't trust that they're going to tell us. So I always say, if we know there is something chronically causing pain, please chronically treat it with whatever the lowest common denominator is, like Tylenol, for instance, to help treat it, because untreated pain causes agitation. And untreated depression means that they withdraw even more, and untreated depression can become psychotic. They can actually become paranoid, suspicious, hallucinatory. So, and the bigger picture, I think, is we have to remember quality of life. We are the only ones who can impact that. How do we provide for their comfort, for their engagement, and their pleasure?
Okay, Hella, we have a couple of extra questions. Is it okay if we go a couple of minutes over? Is that within your schedule? Okay, thank you. We have a question from Shannon, and the question is, do you know if there has been much progress made on prevention, or at least slowing the disease process?
Well, that's the direction of research now. It's only been over the last few years that we've actually been able to move to prevention studies, because now our technology and understanding of the disease is such as that we know some of the plaque and the neurofibrillary tangles, but especially the plaque, is laid down years before symptoms appear. We know that we can now measure that plaque. We can see it. So this is the first time in history, in the 10 years that I've been working here, almost 11, that we are actually looking at disease-modifying avenues of treatment. So the problem is it still takes years to get through these studies, but research is very much what we're looking at in terms of prevention and slowing the disease. We have drugs now that slow some, but don't prevent progression.
Okay, thank you. We have a question from Mara. Her question is, do people with early onset Alzheimer's disease progress through the disease any faster than older adults?
Quite often early, we do see a faster progression, yes.
Okay.
On average, for people, we kind of say from time of diagnosis, 7 to 10 years in terms of longevity. Can be as little as 2, as many as 20, but we often see a faster progression functionally and cognitively in the younger ones.
Okay, thank you. We have a question from Maria. How do you feel about dementia medications?
I feel it's an important part of how we manage Alzheimer's disease. So I think The challenge is that we can't prevent the progression of memory change. These medications have been well studied across the board, and they do help when compared against people off the medication. They do raise the curve, in other words, the rate of decline, but not hugely, and they help preserve some function. So if I can identify the need to toilet and I can take care of my toileting needs for 6 to 12 months longer on the medication, that reduces the demand on the caregiver, for instance. So these medications have effect on memory and thinking, potentially on mood and behavior. So there are times we found that just putting something like memantine or Namenda on helps reduce mild to moderate irritability, for instance, and probably because subjectively the person feels a little more like themselves, a little more alert, a little more focused, or maybe if we've done it at the right time, maybe they've kind of been able to hold on to something that they were just starting to lose. So I think they're an important part of the treatment, but I think the other part is absolutely what do we do outside the realm of medicine.
Mm-hmm. And I believe this is more of a comment from Michelle. In the moderate stage, I have found it is difficult to find activities for my mother. I read aloud to her, take her on a walk, play with the dog, take her to the movies, but I feel like it's not enough. She has a posterior cortical atrophy. Thank you. Cortical atrophy. So severe perceptual vision loss limits what she can participate in. Any resources for activities for someone like this, websites, etc.? I've already purchased aqua paints, and she really doesn't care for it. Thanks.
Yeah. So I think, you've already kind of stumbled on to the activities. So we know that with time, activities will become shorter, and we want them to become more sensory oriented. We want a balance of sort of activities that require more focus with things that are kind of quieter. So what taps into senses are things like aromatherapy or lotions. Now I can pair massage with different scents. Going to a coffee shop or a pastry shop and smelling things and having a little cup of coffee. It creates an outing and it creates something pleasurable. Music is what we call the sixth sense. That is so ingrained on us from a very early age. So can I listen to music at different intervals during the day, and maybe different kinds of music so that it doesn't just become white noise? Can I pair that with a little fun dancing, for instance? Going for walks, the longer we can maintain walking, the better everything is in general. Narrating memories, so she may not appreciate what she's looking at in a picture book, but you can be talking about the family photo album and, oh, here's the picture and it's you and your brother and I remember, or you know what her memory of that is, and so you help her remember, for instance. So it's very much focused on sensory, gardening, doing container gardening, getting her hands in there. All of those kinds of things are important. Consider even enrolling her in daycare. So yes, she has visual perception limitations that may affect some things, but her ability to socialize and to appreciate other activities may well be met in a daycare setting.
Thank you. And this will be our last question of the webinar. Mara is asking, what is the likelihood that a person with Parkinson will develop dementia?
Oh, that's, there's a reasonable chance that they may develop Parkinson's, but it's not an absolute. So we have people with Parkinson's who have nothing but Parkinson's disease, and then we have those who develop dementia several years into the disease, into the Parkinson's. So it's a watch and just keep observation and awareness that may happen.
Thank you so much. And I want to first thank you, Hillebrand, for the wonderful presentation and taking time to answer these questions. I know I certainly learned some new things today as a professional, and I hope all of you who joined us today has learned something new as well. I want to encourage everyone to come back next month on May 11th from 1 to 2 p.m. Eastern Time, and that topic will be Understanding the Journey of Grief with presenter Diane Brennan. I also have included handouts about some of the programs and resources that we have here at AFA, and Hella had included in handouts her PDF version of today's PowerPoint and another helpful handout that you could keep on file. Again, I want to thank you, Hella, for such a wonderful presentation, and I want to thank everyone for joining us today, and I hope everyone has a wonderful rest of the day. Goodbye, everyone.
Bye-bye.